So to get us started for today, I will introduce the group of speakers that we have. I will start with Dr. Daniel Carrizosa, who is the medical oncologist in Charlotte at the Levine Cancer Institute, specializing in thoracic and head and neck cancers. He actually has a bachelor's degree from Duke. Then he has medical training at UNC, and now he's affiliated with Wake. So I think he can technically root for whoever he wants to in whatever sport that is, which you have to appreciate in North Carolina. He is also the Assistant Director for Community Outreach and Engagement at our newly integrated Comprehensive Cancer Center, and does lots of work at the state level and national level with the NC Advisory Council and NCOA, as well as ASCO. Next, we have Darcy Doege, who Darcy is a nurse with over 20 years of nursing experience, including that she was the first colorectal cancer navigator at the Levine Cancer Institute and helped start 2 oncology palliative care clinics. And she runs the lung bus, is the easy way to put that, but she is the RN clinical supervisor for the Lung Bases for Life program that we're going to learn more about today. And last but not least, we have Melissa Wheeler, and you can see all of their bios in the handouts. So I'm just kind of hitting the high points here. But Melissa actually, like myself, did not get her degree in North Carolina, either one of them. She started at the University of South Florida and then got a master's degree in health administration from Ohio University. She has been doing healthcare with a concentration in oncology and equity for over 30 years, and currently serves as the administrative director for the Disparities and Outreach team at the Levine Cancer Institute. And in 2016, we have Melissa to thank for co-authoring a grant proposal that resulted in funding for the nation's first mobile lung cancer screening bus, which is the perfect segue to say, I will hand it over to you all. Take it away.
I think this is the first example poll. So
oh, there we go. That probably was supposed to be my job. So if everyone will pull up the poll, Evie, let's do this together first before they get started. Lung Bases for Life is the nation's first mobile lung cancer screening program, bringing free screenings, education, and support to underserved communities. True or false? And there better not be anybody who gets this wrong. Okay. Overwhelmingly true. Good. I'm glad everyone's paying attention. Good way to start.
And Carla, I'm sorry, we're going to go back for just a moment. We don't have to talk about them, but we do need to show our disclosures to everyone. So our ANCC disclosure and then our ACCME disclosure. And
got it.
There, that is all done. Thank you.
Thank you for bailing me out. All right. With that, I think we can officially hand it over.
yes, so thank you everybody for joining us today to hear about the work we've done here with the Catawba Indian Nation and what our Disparities and Outreach program and now our combined COE program with the Atrium Health Wake Forest Baptist Comprehensive Cancer Center is doing. So, first question. Which of the following cancers is observed in the month of November? People are going ahead. Breast, lung, head and neck, or none of the above. See, everybody's learning as we go along. So, yes, this November is Lung Cancer Awareness Month, started today. Breast cancer was October. That's why everybody saw pink around. Head and neck is actually in the spring. So to just go forth, the objectives of this webinar is to describe the relationship between LCI, as we call it, and the Catawba Indian Nation, to explain the varieties of programs that are offered to the Catawba Indian Nation via the Catawba Service Unit, to discuss lung cancer screening and the use of mobile units in reaching underserved populations, and to describe the early observations found specifically at the work we've done with the mobile screening unit with the Catawba Service Unit. And the outline basically goes along those lines. We're going to describe a little bit about the program, a little bit about lung cancer, the innovative approaches of that, our relationship with the Catawba, the programs we have there, and just what we've been doing in general with American Indians through our community outreach and engagement. So, as probably most everybody on this call knows, cancer health disparities are a huge issue today all over the world, but specifically in the United States and in North Carolina. And to be able to actually meet and try to fix these disparities, we have to take a multi-pronged approach. And all of this involves both prevention and education, screening programs, and most importantly, community partnerships. And throughout all of this, we're strong believers that there needs to be care coordination all through these levels so that we can do this job well and be able to overcome all the disparities and inequity that is in our healthcare system. So what we had at Levine Cancer Institute was our Disparities and Outreach program. It's a very large and active program touching many people every year and with many community partners. We've screened over thousands of patients in over 23 counties in both North and South Carolina, and we have referrals for screening and other assistance in over 25 counties. And we screen more than just lung cancer, but we are known for our lung cancer screening. Importantly, our Disparities and Outreach program has been alive and well and now has happily married with the Community Outreach and Engagement program at Wake Forest to make our now integrated Atrium Health Wake Forest Baptist Comprehensive Cancer Center and our Community Outreach and Engagement program. As Dr. Mesa, our new director, says, we are one cancer center with 2 campuses and 2 doors. And if you want to just quickly look at what our catchment area is for our Comprehensive Cancer Center, it is these teal counties in North Carolina and the Midland or upstate South Carolina, reaching almost 5 million residents with a majority in a very large population in the rural area, over 26,000 new annual cancer cases with unfortunately 9,000 deaths per year in over 30 counties. And to give you a little bit of background on what we see in our catchment area, basically comparing what we have at Atrium Health Levine Cancer, as our service line is now called, or at the Comprehensive Cancer Center, we have an increased incident rate of all cancers and an increased mortality rate of all cancers compared to the U.S. Our major ones are lung cancer, with both increased incidence and mortality, increased incidence and mortality in breast cancer, unfortunately, an increased incidence of oral cavity cancer, as we are in the tobacco belt. And we've been seeing an increase in mortality in liver cancer, which is a new and growing incident cancer throughout the U.S. Now, to hear a little bit about lung cancer, and it is Lung Cancer Awareness Month. Lung cancer is the 3rd most common cancer that we see actually in the U.S. behind breast and prostate. But more importantly, it is the deadliest of all cancers. We have more people die from lung cancer than many of the other cancers significantly, almost twice as much as breast and prostate. And it is unfortunate because we see many people present with lung cancer at a very advanced stage where we can't cure them, leading to this mortality and death. And so we need to find ways to actually make people do better with lung cancer and find it earlier. So, next polling question. If we're trying to find lung cancer early and you present it to your physician, which of the following characteristics per the U.S. Preventive Services Task Force would allow you to qualify for lung cancer screening? Would it be A, smoking at least one pack of cigarettes a day for 30 years, B, being 75 years old, C, having a discussion with your doctor about the benefits and risks of lung cancer screening and whether you should get it or not, D, both having that smoking history and having the discussion with your physician, or E, all of the above, being that age, having smoked at least one pack of cigarette a day for 30 years, and have discussed the risks and benefits of lung cancer screening. Okay. Well, as you'll learn, the answer is actually E. So to talk a little bit about lung cancer screening, before 2011, we actually had no way to screen. We had been doing mammography, we had been doing pap smears, colonoscopy, but for our most deadliest cancer, we had no way to find it early. At that time, many physicians, because they were worried about their patients that had a significant tobacco history or some concern, were doing a simple chest x-ray to actually see if they possibly had lung cancer. But unfortunately, it really didn't work. And lung cancer was not easily found on a simple chest x-ray. And so the question was, could we do better by actually doing lung cancer CTs or low-dose CT scans? So there was a very large study done called the National Lung Cancer Screening Trial. And this actually looked at over 50,000 patients that actually were high risk for lung cancer across the country. And what they did is they actually randomized these patients that were high risk to either getting what's called a low-dose CT scan, which is a faster CT scan that doesn't have as much radiation and does not use intravenous contrast, versus the simple chest x-ray that many of us have seen when people were worried about a pneumonia or some other cause. And the results were very surprising, very encouraging, and exciting. And we found that there was a higher rate of positive screening in patients with low-dose CT. It's a much more sensitive test, so we would find more things. Now, there was a high round of false positivity because a lot of us have actually inhaled something, had a little spot. If we have a significant amount of smoking history, we may have damage to our lungs like COPD or emphysema, and we can get little inflammatory nodules that come and go. But more importantly, the reduction in mortality was 20% compared to actually just doing a chest x-ray. So we were actually preventing death. And that death reduction was 6.7% from all causes, not just lung cancer. So people who were getting the low-dose CT were living longer, not just from lung cancer, but possibly from other things that were found or being tied into their physicians more. So the U.S. Preventive Services Task Force, which makes all the national guidelines for screening, basically in December of 2013 came up with a grade B recommendation saying that we should be doing low-dose CT for lung cancer screening. And this required that insurers would actually cover it under the Affordable Care Act. Now, unfortunately, the government takes a little bit longer than we would expect. And so the Center for Medicare and Medicaid Services approved that in February of 2015. So there was a gap in time where private insurers were covering it, but Medicare was not. And the original screening guide by the USPSTF was for patients that were aged 55 to 80. So if you were 75, you qualified, had a 30-pack year history, which means that you smoked one pack a day for 30 years, or half a pack a day for 60 years, or 2 packs a day for 15 years, or someone in there so you can actually make the math for 30 pack years. You had to be an active smoker or have quit smoking within the past 15 years, so had still a close history of smoking. And something new that is not seen in any other screening is that you had to have this shared decision-making visit with your physician. In other words, to talk about the possibility of these false positives that we're seeing and to understand the risks and benefits of getting a low-dose CT scan and what would happen afterwards. Now, we don't do this for mammography or for colonoscopy, but it was felt that this was important, and so it is part of the guideline. Now, interestingly, recently, what happened is that many different studies were done throughout the world, in England and in Europe, others, the small ones in the US, and we were finding that they were very good, similar results, but we were starting to see that maybe we should screen more people. And so the USPSTF recently changed their screening guidelines to actually decrease the lower minimum age to 50. So now you qualify if you're 50 to 80. And the pack year history is down to 20. So you only need to smoke a pack a day for 20 years or so forth. So we actually are screening more patients now than when it first started. Now, you have to say that, why did we start thinking about other options? Well, we know that all these trials across the world show that low-dose CT in heavy smokers improves survival from lung cancer and from in general. But we also know that not everybody can get these tests because though they are thousands of dollars, they are hundreds of dollars, and hundreds of dollars makes many a difference for many a family. So uninsured, underinsured, and some Medicaid patients at the time did not have access to low-dose CT scans. And more importantly, from an equity perspective, less than 5% of patients in that large study across the country were minorities. So the majority were white Caucasian patients. So we're not seeing the patients that are troubled in our healthcare system. And what else could we do? And simply put, it's all good, but it wasn't good enough. Melissa?
So we had definitely a lot of unanswered questions. Again, how do we increase the screening? I would like to say thank you so much to SciSep for having us here today. Thank you to Tim, Andrew, and John for making us look not so technically challenged. And Carla, thanks for the beautiful introduction, but I really also would be remiss if I didn't thank Catawba Indian Nation for partnering with us in hope and health and healing and really being able to tell a beautiful story today. So we look forward to sharing with you more about how we came up with the crazy idea for a mobile lung cancer screening program and sort of what those outcomes look like. So back in 2015, we really started to take a deep dive into sort of looking at what the trends were. And we do this each year. We sort of look at, we look at national data, we look at state level data, we look at regional level data. We try to identify the trends, try to assess where we might have areas of opportunity to impact prevention areas, to impact incidence, to impact mortality, and to really, most importantly, impact quality of life and survivorship. And of course, you heard Dr. Carrizosa mention earlier, we're the tobacco belt. At times, some even might reference us as the buckle of the belt, because in North Carolina and South Carolina, we see that while much of the nation has really taken a drop in those tobacco use rates, North and South Carolina have remained higher than the national average. And in particular, in some of our rural communities, access is such a tremendous issue. As Darcy will share with you later, when she talks through some of the outcomes of our program, we've really been able to impact those rural communities that have the least amount of access. But one of the things we also do each year and throughout the year is look at our cancer data registry, look at what's happening in our own backyard in terms of what are the volumes of patients that we're seeing, what are the tumor types that we're seeing, what are the staging that we're seeing those patients arrive at, and what does that allow us to do in terms of creating the best possible optimal quality of life outcome. And so When we did that in 2015, which was not much of a surprise because it mirrored much of the nation, we recognized that about 70% of our patients were coming in at stage 3 or stage 4 lung cancer, which leaves very, very little time for us to even manage symptoms, let alone quality of life, let alone impact that survivorship. So we really started thinking through what our experience had been in mobile space. We have a mobile mammography program here called Project Pink. And we had learned a lot in that space with what could happen if you brought care to where people are. Not only did it improve access, but it really began to build communities of trust. And we really approach how we care for our patients with that whole patient care, whole human care perspective. So with our mobile mammography program, we looked at things like, do you have primary care? Do you have resources? Do you have the ability to get to follow-up care if we identify something? And what we started to see was a really high show-up rate. And we really posited, could we do the same thing, not knowing at the time that it was a crazy question to ask, but could we do the same thing in lung cancer? Why couldn't we think outside of the box, think really big and really bold, and think about, can we do this in a different way? And so at the time, we didn't know that a mobile lung cancer unit didn't exist. After about 45 phone calls, I'm not persistent at all. My husband would call it stubborn. I call it persistent. But we landed upon Samsung Neurologica and found that they were really active in the mobile stroke unit space. Same technology, of course, different type of screening, a little bit different of a population, but they had the technology to tell us this could be done. So we really started to think about how could we make a program around this. Of course, important for us was not just to build a unit, because we don't just want to screen and say, here's your results and good luck. We really wanted a programmatic approach, which is where the concept of the Lung Basis of Life program, or Lung Basis for Life program, came about, which we wanted to, of course, elevate awareness. You know, if you have lungs, you're at risk for lung cancer. This isn't just a stigmatized disease, but we wanted to bring awareness to the fact that, you know, the guidelines changed from that simple chest X-ray to a low-dose CT scan. And Darcy, who again you're going to hear from later, was really instrumental in bringing awareness to a lot of primary care practices across our rural areas that were still using chest X-ray at the time. But we knew that screening wasn't enough. We knew that we were going to have to navigate. It isn't often just that first scan that tells us someone has a lung cancer. There was going to need to be some really high-level navigation to get our patients to the next step, but also to navigate them to those resources that they might need to get them there. Things like the transportation, things like good nutrition, things like access to primary care. So navigation had to be a key component that we wanted to wrap in. And then, of course, that intervention step, which is really critical. Can we get you to the pulmonary visit? Can we get you to some of the diagnostics that have to happen after we find something suspicious? So we really fleshed out a program that included all of those components, focusing with community-based education first, the mobile and regional screening that needed to happen on a rotating every 3-month basis to make sure that our patients who needed follow-up could still get that follow-up within a timely manner, the navigation services, and of course, we don't just want to find disease, we'd like to prevent it as well. So tobacco cessation was critically important in weaving this really comprehensive approach. So that was something that we included. And we approached Bristol Myers Squibb Foundation with this really wacky idea. Most folks said to us at the beginning that, you know, it's going to be too heavy of a unit. You're not going to be able to do it. Most folks will tell you my favorite word in the English language is no, because I'll figure out a way to flip that to on. And so we also heard things like it's going to be too expensive. And we heard, probably most frustratingly for us, was that patients weren't going to want to know. They weren't going to want to stop smoking, and they weren't going to want to get on board. They weren't going to want to find out. And so as you'll hear through results, you'll find that all of those things were completely untrue. So we approached the Bristol Myers Squibb Foundation and wrote a grant for $1.6 million. When we came up with the estimates, we had no idea at the time, but knew some of the key components that were needed. One being the mobile unit. 2, we knew we needed medical supplies. We knew we were going to need to partner on that tobacco cessation and be able to provide nicotine replacement therapy. It's one thing to help someone understand the need to quit, but it's another thing to tell them they need to quit, but then not give them the resource to do so. So we worked diligently to kind of map through what that would look like. And then we, of course, partner with our mobile medicine. Atrium Health has a mobile medicine program that parks our unit for us. They help deploy the unit. They do all of the maintenance for the unit. And they also make sure that we're safe day of. All of their teammates are either current EMTs or former EMTs, so that adds an extra layer of best practice support for us. So pushed the enter on that button to submit that grant, and much to our surprise, they decided outside of their normal grant window and awarded us with the full $1.6 million, which landed this lovely beauty that you see before you, which is lung bus number 1. Why we've called it lung bus, we don't know where the genesis of that was, but it came and it stuck, and we love it. It's loaded with a 32 slice portable CT scanner. And what you see on the side, there is sort of a bump out that allows for the table to slide back and forth so patients can get on board, get their scan. And the unit itself, the CT scanner, is lead lined. Darcy will tell you more about the outcomes, but I will share that on the first screening date that we had in 2017 in April, we had 3 patients and a drive-by shooting. So that was a unique day, but it didn't deter us from continuing to really show up in the communities that need us. But it also demonstrated that bringing care to where people are is something that starts small but grows bigger and bigger and bigger and better. So our success with the first unit allowed us to apply for a grant for a second mobile unit. And we applied. This was through the Levine Foundation, the founders of the Family Dollar chain. And they were able to support us in the construction of a second mobile unit. Some of the staffing needs that we saw through the program, things that we wanted to keep as important to that whole human care assessment, navigation, triage, and follow-up. And so that allowed us to create the second unit. You see here, different style. That was chosen, the style itself was chosen differently by Samsung Neurologica. They partnered at the first time with Fraser Trucking. The second time they partnered with Winnebago. What's unique about the Winnebago style is it does have space in the back that allows for consenting. And Darcy will share with you a little later in the presentation about clinical trials that are currently running with the program. When we talk about clinical trials, we often hear in that equity space and in disparities, our underrepresented communities don't have access. Oftentimes it's because it's either not offered or they can't get there. And so this allows that to happen beautifully. And you'll hear, again, more about some of the outcomes as that has come about. And let's see if I can get our video to play. I promise any technical challenges are completely mine if they don't work, but there we go. This gives you a bird's eye view of what it looks like. So as you can see from the video, we are committed to Chick-fil-A here in the Carolinas. Somebody was having a little lunch that day, but we are upfitted with a wheelchair ramp so that we can also provide access for patients who have accessibility issues. So we can screen wheelchair patients on board. You saw the CT scanner itself, the lead-lined round dome that you saw there. They actually use those portable spaces in the hospital. But it's not fancy, but it has exactly what we need to care for our patients in the safest way possible. You also saw that our team always sets up outside the unit. One of the things that sets this apart is, again, that trust issue. No one has to knock on a door and ask for permission to come in. We're already set up outside with smiling faces and welcoming voices, and it feels very much like coming home. It's always a very casual setting. We have patients that come up that are still currently using tobacco products, and they're not shamed for that. They're not stigmatized for that. This is meant to be a place where they feel safe in getting the care that they need. This is part of our team that you'll see here. I think this photo was taken during the COVID days, which I'd like to think they're in the past, but of course, we have our mobile medicine tech, our driver there. Was not required based on the size of our unit or the weight, but again, it's a best practice. We have an advanced practice provider, a physician assistant named Kia Dungan, and she is just a giant when it comes to our tobacco cessation program and assessing those patients and creating their plan of care. Also has been, instrumental in doing writing for walk-up orders and head and neck screening, education. So incredibly important to have her on board. She does a lot of auditing of our patient cases. We do have, of course, Darcy Doege, our ferocious clinical nurse supervisor, who she really breathed life into this program and got the air in the tires and got the bus rolling from day one. She always says she was crazy enough to drink the Kool-Aid I was serving, but I'm so proud and honored that she did, because it's allowed us to take care of a bunch of really important people across our 2 states. We also have a unique position on our team called a cancer program development specialist. They are the boots on the ground, public health, social work kind of representatives who take those barriers. We don't just ask, do you have difficulty filling your pantry with food? Do you have difficulty getting to your appointments? Once we identify that, those cancer program development specialists work really diligently to plug in resource both immediately and then later on down the road for long-term community-based support. So we also have a CT tech who performs the scans for each patient. So not a huge team, but very critical for each and every step of the way. Again, of course, our guidelines, Dr. Carrizosa nicely went over how those update. We screen only uninsured, or those Medicaid patients because they need that high degree of follow-up. We do not bill for any of our service, and we connect each and every patient to financial assistance for the follow-up care, because the worst thing we can do for someone is to screen them and not make sure they have a mechanism for that follow-up care. And none of us, or some of us might be clinicians on this call, but I think all of us can clearly identify a couple of problems, one of which this particular individual probably needs to either empty the pack or go get a new one. If you look in the upper corner, this was actually one of our patients on an early scan who got a scan with his pack of cigarettes still in the pocket. So this just demonstrates to you that in our communities, it's a real issue, but just because it's an issue doesn't mean it's one we can't tackle together with a high level of trust, partnership, and education and continued follow-up. So I am now going to pass the baton to the wonderful Darcy Doege.
Thank you. I must admit that when I saw the video of the inside of the truck, I got a little nervous thinking it's not the cleanest. So my apologies. But we were out in the middle of the parking lot and people were hungry, apparently. So full disclosure. But just to run through kind of, Melissa already touched on this, but as she mentioned, Kia Dungan is kind of been the mastermind and the oversight of our tobacco cessation program. That has grown into something much bigger than we had originally started. It was amazing because when Melissa first wrote the initial grant proposal, she hit every nail on the head of like where we needed money, and it was insane. I don't know how she did it, but our tobacco cessation program is very robust, and we enroll anywhere from 5 to 10 individuals per screening day. With the Catawbas, we don't have a really good idea with our relationship with them because they have their own tobacco cessation program, which is amazing. And so we were kind of referring patients back, but I think we might revamp that and kind of collaborate a little more going forward on that. But as Melissa said as well, we are fierce navigators for these folks because our patients, they trust us to not just take care of them for their lung screening, but for them for so many other reasons. So we assess for food insecurity, transportation, housing insecurity, other health issues, primary care needs. We really do a full assessment on them while we have them there. And now we do our tobacco cessation initial consult on site when Kia is available to be there. And just being able to do that right when they're all in front of us is amazing. We also have certain screenings that the rest of our team comes and offers free prostate screenings, Fit for Life, which is our colorectal screening program, just all on site in that one day. And that is just groundbreaking for our patients. They are so grateful for the service. The primary cares are grateful because a lot of times the free clinics don't have those services available. So that has really helped our community partnerships grow as well. And then the follow-up and navigation, this is crucial. Every time we have new conversations with any new community partner or provider, they want to know, how do you do this? How do you plug people back into care if they don't have insurance, if they don't have transportation? And I am not lying when I say it's one patient at a time and we figure it out, because it's literally what we have to do. And we are fierce. I always tell people that I think that the reason why I'm so good at navigating this population is because of my background in palliative medicine, that we were, handing out lots of narcotics to folks. And I said, I didn't threaten them, but I came close at times, saying, if I can't get a hold of you when I write you this prescription, or my provider writes you this prescription, then there's going to be a huge problem. I will, send the police to your house, because, it's scary when you're giving away so much medication. And it's also scary when you're screening people and you don't have a mechanism for follow-up. So I feel very passionate about that. So this is a little bit of our data. This was published last November. We obviously have screened quite a few more patients, actually close to 1,000 more patients or more. But this demographic breakdown has stayed pretty true from the very beginning. Our racial and ethnicity background has stayed the same. We are much higher than the national average in how many we focus on for African American and the Latino population as well. And then, as you can see, the rest of the ratios that break down male to female, median age, which I think that all matches up pretty much with the national guidelines. The average pack year, 50 pack year, I think it's up to more like a 60 pack year going into 2023, with our highest at like 125 pack year. And these folks started when they were 6, 7, and 8 years old, like Melissa said. And the thing is that we don't judge them. We don't judge them for anything that they're doing, for anywhere they've come from, for anything that they're going to do in the future. We just want to get them help when they need it. And then the data on the right is just, our breakdown, and we are at a 27, we had 63% early stage. So that is huge for us, as the data rolls in more, I'm sure everybody's seeing this in their programs, but there's, more lung rods 2s getting diagnosed before their annual screening coming up. And that's interesting that could be something that's potentially coming up for more research. And yeah, the potential savings, 1.6 million per patient for late stage diagnosis. Nobody needs to tell you what that means. So a polling question: by bringing the mobile lung unit to the Catawba Health Service Unit, one cancer screening was increased by A, 1 to 20%, B, 3 to 40%, C, 5 to 60%, and D, 10 to 100%. And I think we might have some cheaters on the line, because I think Yvette, Tanya, and maybe Holly, all that are our amazing human beings that have grown this relationship so successfully, are on here, and they already know the answer. So I'm not calling you guys out. I'm saying thank you. But it looks like everybody's settling on D. And you are correct. This slide doesn't apply to that, but I'll get to it. And so you guys were correct with D. And so this is just a quick breakdown of our under 55 clinical trial, which should be called our under 50 clinical trial, because we put this into fruition and rolled it out before the guidelines changed. So, which is very confusing to people. But we're not going to the IRB with anymore. We're just not. So we are seeking patients 40 to 50 years of age with a 20-pack year smoking history, regardless of insurance, as we had talked about. So exclusion criteria is obviously if they've had a previous diagnosis or contraindications to low-dose CT or pregnancy. So the procedures are really, and this is not completely up to date because with the new T0 implementation for the lung rad scoring, not to get too into the weeds, we actually are offering patients anywhere from 3 to 5 scans, depending on what their follow-up needs are. And so these are folks that, I mean, 40 to 50 years of age, they still, even if they do get this pocket of scans, they still won't be offered to enroll into the national guidelines until they turn 50. And so we are finding our positive rate for this statistically matches up with where we needed it to be at about a 14% positive rate, which is lung rads 3 or 4. And so we have screened a total of 432 accrued into the study. And out of the total number that we screened with the Catawba Service Unit, 39 of those, which is about 45%, were under 55 enrolled into the clinical trial. So this really benefited our partnership, having this study open before we started our relationship with them. So that has been a huge impact with this program in this relationship. So the Catawba Indian Nation, this is just a little bit of information about the population. Thank you, Yvette, for providing this to me, and Dr. Carrizosa and Melissa. So it's the only federally recognized tribe in South Carolina, and that is something that I learned when Holly did and her team did a webinar with us that's been relatively recently. And when I say that, that's within the last 10 years, or maybe even closer to 7 years, that they actually finally became a federally recognized tribe. And our partnership with them started because they had a need for a patient that had a very obvious GYN, most likely going to be a cancer issue going on, and they could not get her into care locally because of her insurance status, among many other things. And their team reached out to Melissa, and they swooped her in and got a very quick diagnosis for her. And that just blossomed into an amazing relationship that Melissa and Khaki Higgins on our team started. And just, like Melissa said, doing a needs assessment, figuring out what needs they had. And as you can see, the breakdown for the number of folks that live on the reservation, that's why we decided to bring the mobile units to the reservation and only screen the patients that they had there that qualified. We have other opportunities of screening in Rock Hill, but we try to be very respectful of the land and the staff and the patients, and just screen those that come on site for those days. We also have screened a lot of, their family members, partners, and that has been a huge impact as well for our relationship. And the Catawba Service Unit, this might be on the next slide, but I just want to make sure I don't miss it, serves the entire southeastern side of the United States. So there's other tribal members that come in to seek service from hours and hours away for the federally funded programming that they have here. So we have not run into navigating a patient that lives down in Georgia yet, but it is something that we are very aware that could be the case, and we're just going to have to figure out how we're going to do it. And I think this is my last slide. So this is just a poster that Dr. Carrizosa, Dr. Ragman, Melissa, myself, Kia, and Holly were able to compile the data for the Catawba Service Unit. But total of 91 screened, 61 median age, so that's very similar to what we have in our regular program. And then 48 pack year average. So that's a pretty high pack average in comparison. And then you can see the demographic breakdown of the 68% of them did have some form of health insurance without significant coverage to provide lung screening. So just a highly underinsured population. And I think that's all I have, and it's back to Dr. Carrizosa. Oh, no, it's back to Melissa. I apologize.
That's it. You're in big trouble.
I know, sorry.
I did see Tanya and Holly and Haley on here, so thank you all so much for joining us and being such great partners. The work that's done there is just absolutely incredible and inspirational, and has led us to further projects that we've been able to partner on together. We always like to say that a human being is a whole house, and you don't want to just take care of one hallway, because it could be the kitchen that's on fire. And so if you ignore the kitchen, but you're taking care of the hallway, the whole house could burn down. So chances are, if you qualify for our free lung screening, you're going to qualify for many other programs that we can offer the same type of full support. One of those being our mammography program and our diagnostic entry point mammography program. So we've been able to introduce Project Pink and Project Pink Plus. Project Pink is that baseline mammo, no signs or symptoms, but simply qualify for a mammogram. And Project Pink Plus is our program that's really open to a man or a woman who might not qualify for baseline screening because they already have a sign or a symptom, but they don't have the coverage to get them through that program. So we were able to partner and bring the mammo bus out. And by doing so, we provide all those that are eligible with tomography, the 3D mammo, and ultrasound biopsy, all the way up through breast cyst aspiration if we need to. We had our first 3 screenings in 2022. For 71% of the women we screened, it was their first time mammo. We continue to screen there this year, and we're going to keep coming back as long as they allow us and as long as we continue to grow this wonderful partnership. One of the other things that's also really incredibly important to us, again, you heard me say, it's not enough to detect things, we've got to prevent too. And in North and South Carolina, you only need 1 semester of health and PE combined to graduate. That's out of your entire school career. So we're not growing healthy adults in our 2 states. So we provide a program called ICAN. It's a youth cancer ambassador program where we teach young people to be the best police of their communities in terms of health. We expand our cancer prevention education. We have 2 curriculum, and it goes all the way from kindergarten up through 12th grade. We're in 20 different counties at this point, and we were able to introduce this to our friends with Catawba Indian Nation. We look at things like what is cancer and how to take the fear out of that by empowering our youth to know what signs and symptoms are, what tests are needed. We talk about healthy nutrition and how that relates. We introduce things like physical activity. I recently learned that, and this is going to come terrible on the heels of Halloween for some of you, but you have to do approximately 435 jumping jacks to take away the calories from one of those little tiny 3 musketeers. And that's part of what we teach in the course, right? Is just helping young people to understand what they consume can have a long-term effect. We talk about things like mindfulness and stress reduction, of course, tobacco use and all of the impacts there, then HPV, colon cancer, and breast cancer awareness. So again, really not just wanting to, find disease, but help to prevent long-term. So you can see some of our youth ambassadors that we've taught across our region. These are actually some students from Chapel Hill that we recently taught. So we have what we call a train the trainer program. We provide all the resource. We train the trainers, these young adults, and they can then go out in their community and teach with all the supplies that we provide. Gives experience for resumes, but also gives them Amazon gift cards, and also really motivates them to take care of their own community. So we were able to introduce that program as well. Dr. Carrizosa, back to you.
So we're very proud of our relationship with the Catawba, and it's very important. And I think now, as we have integrated into the Atrium Health Wake Forest Baptist Comprehensive Cancer Center, the Wake program had already had a strong commitment to American Indians by hosting the North Carolina American Indian Health Board, and by actually looking at the factor that North Carolina has the largest component of American Indians in any state which is east of the Mississippi. So we have had a very strong collaboration and continue that with SICEP, and are very pleased that SICEP is happy to have our collaboration with them. And we are working to expand North Carolina tobacco research into the Catawba Nation. And that's work from Dr. Denglinger App, who is up in the right corner. Importantly, with Dr. Denglinger App, we have come together and actually created Case for Cancer, which is a new program that's coming through the Wake Forest Baptist Comprehensive Cancer Center to help with cancer screening education by doing videos, new types of programming, handouts, and we're going to try and work on creating tribal liaisons in all the tribes that we can get to join to actually increase cancer screening as well as help with tobacco cessation. So it's very important to us to be able to actually help our American Indian community throughout the state of North Carolina and South Carolina. So we are very pleased to be working with all of you. Finally, I just wanted to show a quick slide with all of our team members here. And I wanted to then come back and thank both SciCep and Tim and Andrew for letting us spend this time with you today. It's very important that we're able to get this across. And we also want to make a very strong thank you to the Catawba for letting us come in and work with them and be able to help their community, as well as all the other American Indian population in North Carolina that we are serving. So thank you very much for all of your attention and your help. And these are the references that we have that are available in your handout. And now, time for questions and discussion.
Thank you all so much. Every time I see that presentation, I learn something new. We can be low tech or high tech with the questions. So if it's easier to drop it in the chat, please feel free to do that. Or you can use the poll EV to share questions with the presenters. So we have our first question through the poll EV, which is, please talk more about the Cancer Program Development Specialist. I would like to know more about this person's activities and training. I'll let you all decide who wants to take that on, but I have a feeling that'll be Melissa.
Yes, I will be happy to answer that question. So for someone to qualify for the Cancer Program Development Specialist position, we look for either public health background, social work background, but we especially look for someone that has worked with underrepresented communities, someone that has experience in healthcare, someone that has a deep working knowledge of the courage it takes for our patients to come forward and ask for help. And someone who can be really sensitive to the needs and be really responsive to developing and delivering resources. In terms of their activities, it depends on if they are part of the screening team. With the lung bus screening team, they do some education. They do a lot of resource navigation, things like food pantries. They work with housing resources. They can actually help in the field with applying for financial aid through the hospital system or help with things like Medicaid applications. But we also have Cancer Program Development Specialists on our team that do freestanding education opportunities. They work with different community partners like AmeriHealth, which is a Medicaid managed care organization where they do programmatic education throughout the year. But even with our education programs, we do that same resource navigation, because even if you're not there for screening, chances are if you're partnered with one of our clinics or one of those community partners, you're going to need resources. So they do a lot of that resource assessment too. And then they conduct other types of screenings, such as our Fit for Life colorectal cancer program, where they do education and then provide the FIT card, same resource navigation.
Awesome. Thank you for tackling that, Melissa. And I'm sure I will speak for everyone here today presenting, but please feel free to reach out if there's any additional questions or resources or information that anyone can provide. Okay, so we have another question, and there's lots of thank yous in the chat as well, so I don't want to forget to mention that, but it says, I'm curious about provision of services to those who are not covered by IHS or are uninsured or underinsured in terms of how that impacts their ability to acquire follow-up care. Any thoughts about how best to bridge these insurance gaps for American Indian populations specifically?
So that's a really tough question, but yeah, because as we know, the Medicaid expansion is not happening in South Carolina. So let's take that conversation out of the equation, because we don't have near enough time to even, commiserate over South Carolina Medicaid as a whole anyway. But and with all the changes in just commercial insurance, we're finding more and more patients that are getting misguided with Medicare guidance with their supplemental, which choices to make. My parents were just here. My mom sells Medicaid supplements, and she said that people are calling and saying, hey, you can save this much money, and not giving patients information. They're getting duped on what they're getting signed up for. That's a huge barrier that we're running into with all patients, regardless of their, ethnicity or race or their demographic breakdown. But as far as like our specific uninsured patients or underinsured patients that we follow, how we kind of deal with it is, what's the biggest barrier? All of our patients are presented at nodule conference, and the conversation could go 3-month follow-up or jump to a PET scan. And we bring up and advocate, hey, they don't have insurance, or they have this Aetna plan that is high deductible. Can we consider this instead of that? And where do we need to get them in for care? We had a patient down in Rock Hill that couldn't get in with a pulmonologist. They just would not see the patient unless the patient could pay money up front. And so we pivoted and brought them into another location that wouldn't charge them, that $100 to $150 up front. So it is literally a patient by patient situation. The biggest problem that we run into is negative PETs that aren't covered. And sometimes we just beg with the radiology group and say, hey, can we get this knocked down to a lower price or a payment plan, or, and somehow we figure it out. So, but yeah, that's a legit question with specifically to the American Indian population. I think it's just something that more education on which commercial insurances, even through the marketplace, that is this worth your money or is it not? Because a lot of people are paying in $400 or $500 a month, and they're not getting anything in return from that insurance plan, and they're ending up paying more. And it's, if you have to choose insurance, your cell phone, your car insurance, your power, what are you going to do? You're going to give up your health insurance.
I would say the other thing I would add to that is we have to remain exceptionally vocal in where the gaps are. And that includes internally with our own health systems. Sometimes the health system itself, even though the mission or model might be care for all, they don't recognize all of the things that stand in the way between a patient getting to that care for all. And so I think we have to be really loud in our advocacy in terms of, hey, it's not enough to say the gaps exist. Now, what are we going to do about it? And so really trying to design and innovate as well, thinking differently about how we approach unique situations. It's not enough to just say the gap's there, but what are we going to try? And the only way to bake a cake is to turn the oven on. And so we're constantly challenging both internally and externally. Let's all turn the oven on and see what we can make. It might not come out our favorite the first time, but if we keep at it and we keep trying and trying and trying, we're going to see a different outcome each time, and we're going to see our ability to care for people to grow.
And just real quick, our team actually, by navigating patient by patient, actually starts trying to figure out what is the best way to do this. And we work with multiple healthcare systems. We will find the paperwork and help with the Duke healthcare system or with UNC. It doesn't mean you have to end up coming to Advocate Atrium. So with the person and the patient is the most important thing, and that's the person that's first.
All right. I think we're right at 1 o'clock. We have one question left. If somebody can give a quick answer, it says, please talk about the work needed to prepare a community for a visit from the bus. Press releases, publicity, networking. How does that work?
All Darcy.
Yeah, that's been my whole job. But yeah, where it starts is literally boots on the ground education with every single clinic partner. I kind of require face-to-face. COVID hit me hard with that, but face-to-face, building that relationship. My husband always tells me I need to be in sales, but he's like, then you would just give people stuff for free anyway, so it doesn't really matter, which is true. But really it's selling the program, selling the need. And then after you get that date established, we require 15 referrals to kind of start the introduction, because then we have to continue to come back every 3 months. So once we're committed to the county, we want to keep the ball rolling and keep referrals coming in so that we can keep coming back to screen more patients. But sometimes we do press releases, sometimes publicity, but sometimes press releases have gone wrong because they've given misinformation. In like a small town newspaper where it said free lung screening with no criteria. And people were fired up about that. That did not go well. So yeah, we've learned a lot when it comes to that, but it really is just the boots on the ground community partnerships and education that we've done.
Perfect. Thank you, Darcy. I want to just reiterate a thank you to all three of our speakers, Dr. Carrizosa, Melissa, Darcy, for sharing this amazing work with all of us. I think there's so much we can learn from the experiences that you all have already had in how to better serve our underserved and American Indian communities around cancer screening. And again, please don't hesitate to reach out to any of us if there's anything that we can help with to follow up. And thank you to UNC for hosting us on their platform. And please stay tuned for future SACEP webinars and opportunities to hear about more important work in American Indians and cancer. Everybody have a good first unofficial day of winter in North Carolina.